Good morning friends. In this video I am going to explain about coronavirus, its structure, the mode of transmission, pathophysiology and clinical manifestations. This video is meant for the students and staff who are working in the battlefield of COVID-19. So I am sure that all of you are familiar with the virus, which size, shape, structure. All of us are updating our knowledge regarding the number of cases in the world, in India, in Kerala, and so we know that in the world the number of cases are increasing, that is 1.18 crores as on today, and the number of deaths in the world 5.5 lakhs, and in number of cases in India it is 7.2 lakhs, and the number of deaths in India it is more than 20,000, and in Kerala more than 6,000 patients, and we have lost nearly 25 patients in Kerala, and we know that so many Malayalis lost their life in abroad, that is in the Gulf countries and US and other countries. So let us review the structure of the virus. So we all know that it is a spherical shaped virus with so many spike proteins around it. So these proteins, surface proteins, are protective for the virus. So we know the structure. The virus is only 120 nanometer in size, and it has got a spherical shape. It has got surface proteins. There are many types of surface proteins. That is, there is S protein or surface protein, then there is E protein is there, M protein is there, hemagglutinin esterase, that is another one. So these are the different things on that covering of the virus. So, and inside that there is an envelope is there, inside that there is nucleocapsid is there, and in the center there is viral RNA. So this is the structure of the virus. So we must know the structure when we look into the pathophysiology, and when we go to the management with the pharmacological agents, then you must know the structure of the virus. So that is about the structure of the virus. So we all know that this SARS-CoV-2, novel coronavirus, it is a genetic variant of the SARS virus and MERS virus. SARS infection and MERS infection, we may be knowing that is in the 2002 SARS infection has occurred, and in 2012 a MERS infection has occurred. Both these were due to coronavirus, and this is more or less similar to that virus only. So this is a beta coronavirus, and actually this coronavirus infection is not something new. This particular genetic variant is showing these extraordinary features and the extraordinary symptoms in the patients. But coronavirus is known from 1960s itself. It is causing milder upper respiratory tract infection, and it was coming like that, and it was modified into SARS and then MERS, and in 2019 it has come as COVID-19. So that is about the history of the virus. So when we look into the mode of transmission of the disease, we all know that in a 1 meter distance or a 6 feet distance, now it is said that 2 meter distance is required. So in that distance, if a patient coughs, sneeze or talk, the other person standing or sitting near will get the infection. So that is the mode of transmission, that is droplet transmission. I told the size of the virus, it is only 120 nanometer in size. Okay. So there are other modes of transmission also, that is fomite transmission. That is, these droplets from the patient will fall on the different surfaces, and it will contaminate those surfaces. If somebody else come and touch those surfaces, and that person touch his eyes or nose or oral cavity, then there is chance of getting infection in that person. Okay. So in the based on the type of surfaces, the duration of survival of the virus in that surface will vary. Okay, in the this copper, latex and aluminium, this virus will survive for 8 hours, and in case of cardboard it will survive for 1 day. And in plastic and stainless steel, it will survive for 1 to 3 days. And in this glass and wood, this virus will survive for 5 days. So you must remember, in glass and wood, this virus can survive for 5 days, up to 5 days. So whenever somebody else come and touch those surfaces which is contaminated with the virus, and he will touch his eyes, nose or mouth, he will get the infection. So that is the most serious matter which we have to remember. We may be going to the shopping, we may be going in a public transportation facility. So if the surfaces are contaminated, you will get the infection. If the electric switchboard is contaminated, you will get the infection. If the door handle is contaminated, you will get the infection. So that is the importance of hand washing. So that is about the contact transmission or formite-borne, that method of transmission. That is the second one. Then the third one is airborne transmission. So far WHO claimed that this is not an airborne infection, though it may spread as airborne in ICUs where aerosol generating procedures are done, that is suctioning and nebulization and all. Then there was it is considered as airborne infection. Otherwise, it was not considered as an airborne infection. But now the scientists are coming with the evidence that this is a airborne infection. That means this can survive in the air for many hours and this can cause infection to others. So droplet infection, swarmite-borne infection and airborne infection. So these are the mode of transmission. So we all know that from one person, this infection can go into 3 persons. It will take 4 days. So from that 3 person, another 3 person, like that 9 persons will be infected. From those 9 patients, another 3 patients each, like that 27 patients will be infected. So I told from 1 person to 3 person, it is 4 days. Like that, by 12 days, what will happen? Total, this 1 plus 3 plus 9 plus 27, like that it will go. It will be 40 patients will get infected within 12 days. So 1 person is the first case. So that we must remember. So that is about the mode of transmission. And now I am going to explain about the other aspects of the epidemiological aspects, that is the incubation period. All of you know that the incubation period is 5 to 6 days with a maximum of 14 days. That is why we are keeping the patients in quarantine for 14 days. So this incubation period means the entry of the microorganism till the onset of the symptom of the disease. Okay, so that is 5 to 6 days. So that is about the incubation period. Then next is the period of infectivity. This period of infectivity is more, if this infection is more infectious, 3 days before the onset of symptom and 3 to 5 days after the onset of symptom. That period is the highly infectious period. Okay. So in the earlier stage and the later stage, the patient is not that much infectious. That you must remember. When the patient come to the ICU and all that, at that time, that the patient is not that much infectious. So that we have to remember. Then that's about the mode of transmission and the incubation period and period of infectivity and all. Next, I want to explain about the pathophysiology. We all know that through the droplet from the contaminated surface, the virus will enter into the new host. So in the new host, through the nasopharynx, through the trachea, bronchi and bronchiole, it will reach the alveoli of the patient. So in the alveoli, it will mainly affect the type 2 alveolar cells. Okay, there are 2 types of alveolar cells: type 1 alveolar cells, which is meant for the gas exchange, and type 2 alveolar cells, which will produce the surfactants. So this type 2 alveolar cells are affected by the virus. So the virus will come and attach on the surface of the type 2 alveolar cells. Okay. So now the virus is on the surface of the type 2 alveolar cells. So it will get attached and fuse with the wall of the alveolar cell. So on the wall of the alveolar cell, there are 2 things, that is ACE2 receptors, that is angiotensin converting enzyme 2 receptors. It is there on the surface of the type 2 alveolar cells. Then transmembranous protease is there on the surface of the type 2 alveolar. So these 2 will help the virus to get attached, to fuse with, and to enter into the inside the alveolar cells. So I hope it is clear. So thus the virus will enter into the inside of the type 2 alveolar cells. Now the virus is inside the type 2 alveolar cell. In the type 2 alveolar cells, the virus will undergo so many processes, that is called endocytosis. Okay, so in the endocytosis, the virus will come inside the alveolar type 2 alveolar cells, and inside it, what will happen? Uncoating of the protein. So I told the viral protein is a protective cover of the virus. So inside the alveolar, it is safe inside a cell. No? Now, so it will uncoat its protein. So now it is without protein. So now the RNA is free. So after uncoating, the RNA will be released into the cytoplasm, and this RNA will undergo translation, and it will result in production of more viral RNAs. So from one RNA, more viral RNAs will be produced. For this, an enzyme is required, that is called RNA dependent RNA polymerase enzyme. So with the help of this enzyme, from one single RNA, many RNAs are produced. Okay. So this enzyme name you must remember, because in the management part we will be discussing about the some drugs which will act on this enzyme. So that is one thing which is happening. Then from the RNA, there will be it will undergo transcription, translation, and all. Then there will be a production of so many polyproteins. Polyproteins will be produced with the help of an enzyme called protease. Okay, that protease also you must remember, because some drugs are acting against this protease. So this protease is an enzyme which helps to produce so many polyproteins. So these polyproteins are the initial units of surface protein of the virus. You may be remembering the surface proteins of the virus. So these polyproteins are the initial units of the surface proteins of the new viruses. Now I am explaining about the viral replication. So from the single RNA, many RNAs are formed. From the viral genome, so many polyproteins are produced. So these polyproteins will be converted to the surface protein. So like that, now inside the alveolar cell, there are new surface proteins are ready. There are so many RNAs are ready. So now what is going to happen? This must be assembled and a new virus must be formed. That is a formation of new virus. So assembling of these viral components or viral units and making a new virions, that is the next process. So integrase is an enzyme which is helpful in assembling the units of the virus and making it into new virus. So integrase, that enzyme will help in this process. So like that, new viruses will be formed in the Golgi apparatus of the cell. So when the new viruses are formed, new virions are formed, it will be released out of the cell. It will go out of the type 2 alveolar cell. Now the new viruses are outside the type 2 alveolar cell, and they are ready to attack the other cells, and they are ready to go out and infect other people. Like that it is there. So that is happening there. Then what I want to tell is, because of all these process, what will happen? This type 2 alveolar cell will become damaged, destructed. Okay. So because of this destruction of the type 2 alveolar cells, two things will be produced. One is damage associated molecular pattern, and another thing is cytokines. You may be knowing that cytokine is the dangerous thing in this infection. So cytokines are produced, damage associated molecular pattern is produced. All these will alert the alveolar macrophages. Macrophages, you may be knowing, the important part of immune system. So these alveolar macrophages are activated with the help of this cytokines and damage associated molecular pattern. So because of the activation of the alveolar macrophages, so many inflammatory mediators will be produced. For example, interleukin 1, interleukin 6, interleukin 8, then gamma interferons, then tumor necrosis factor. All this will be produced as a result of the activation of the alveolar macrophages. Okay, so that is one thing which is happening. And then another thing is, because of the effect of these inflammatory mediators, the pulmonary capillaries which is outside the alveoli, this pulmonary capillary wall will be damaged, and the pulmonary capillary permeability will be increased. And because of the increased capillary permeability, there will be extravasation of fluid from the blood vessel into the interstitium, and from the blood vessel into the alveoli. So this will result in interstitial edema and alveolar edema because of the increased capillary permeability of the pulmonary capillaries. So that is one thing. When there is edema, there is interstitial edema, there is alveolar edema. So the distance between the oxygen in the alveoli and the blood in the pulmonary capillary will be more. That means there is thickening of the alveolar capillary membrane because of this edema. So that is one thing happening. That is pulmonary filtrates, we can say, consolidation, we can say, fluid accumulation, interstitial edema, alveolar edema. That is the event that is happening here. So that is there. Then that is one thing. Then another thing is, because of the action of these inflammatory mediators will damage the vascular endothelium of the pulmonary capillaries. So pulmonary capillary vascular endothelium is damaged. As a result, this vascular cell adhesion molecules will be produced. VCAM, vascular cell adhesion molecule, will be produced as a byproduct of the damage of the pulmonary vascular endothelium. Okay. So these vascular cell adhesion molecule, what they will do, they will also are interested to create problems. That is, they will wait there inside the capillaries and they will attract the WBCs going through the blood, and they will attract the WBCs. So, and along with the vascular cell adhesion molecule, WBC also is there now in the adhered form in the blood vessel. This will go out of the blood vessel. This WBC, which is adhered to that molecule, will go out of the blood vessel and enter into the alveolar. From the blood vessel, WBC will enter into the alveolar cells, into the alveoli, and they in the alveoli who are waiting there to make problems. In the alveoli there are so many cytokines that they are waiting to create problems. So this when the WBC comes, when the neutrophils come, what the cytokines will do? The cytokine will activate the neutrophils and will perpetuate the inflammatory process. So as a result, this neutrophil will become activated and neutrophil start producing inflammatory mediators. Neutrophil will produce protease, reactive oxygen species, etc. And thus it will again perpetuate the inflammatory process. So that is happening in the alveoli. So these are the different things which is happening in the alveoli because of the attack of the virus. Then another thing is, because of the inflammatory mediators like interleukin and all, interferons and all, and this procoagulant proteins will be increased and anticoagulants will become, protein will become decreased. So this anticoagulant protein will be decreased and procoagulant will be increased. As a result, there will be chance of formation of thrombosis, thromboembolism, pulmonary embolism, pulmonary infection and all. And later it may go into another severe condition that is called disseminated intravascular coagulation. So that is the after effect of this coagulation problem, that is increase in the procoagulant and decrease in the anticoagulant, that will result in thromboembolism and that will ultimately lead to DIC. So that is one thing. Then because of this pathophysiological mechanism, so many clinical features develop. So now I am going to the clinical features. So when we look into the clinical features, in the clinical features, fever will be there. In case of any other infection, fever will be there, cough will be there. This cough is because of the action of these inflammatory mediators on the CNS. So the interleukin, bradykinin and all, it will activate the receptors in the vagus nerve, and then from there it will stimulate the CNS to produce cough reflex. That is one thing. Then this bradykinin and leukotriene and all will stimulate the bronchus to prevent further entry of microorganism. That will result in bronchial constriction. That is one thing. That will result in breathlessness. So that is the cause of breathlessness. Then I told about cough and then I told about breathlessness. Next is fever. The interleukin, bradykinin and other inflammatory mediators will influence the CNS and will influence the thermoregulation. It will change the levels of the prostaglandin and thus the temperature will be increased. So like that, because of the pathophysiological changes, so many clinical features develop. That is fever, cough, breathlessness, etc. Then when we look into the other clinical features of patients with COVID-19, we can say there will be usual features of upper respiratory tract infection will be there. That is, fever will be there, nasal congestion, sore throat will be there. Then respiratory features will be there, like cough will be there, productive cough will be there, secretion will be there, breathlessness will be there. Then other symptoms, general symptoms like fatigue will be there, myalgia will be there, headache will be there. Then if there is in some patients GI symptoms are there, like anorexia, nausea, vomiting, diarrhea, etc. Then if the other systems or other organs are affected, the corresponding symptoms will be there. That is, if the taste cells are affected, there will be lack of taste. If the olfactory cells are affected, it will result in loss of smell, that is called anosmia, hypoanosmia, okay, etc. And based on the complications, other symptoms also will be there. That is, if the cardiac involvement, there will be features of ACS. If the liver involvement, there will be features of metabolic derangement. If the kidney is affected, there will be decreased urine output will be there. So like that, based on the complication, the symptom will be there. Where if there is sepsis, features of sepsis will be there. If there is septic shock, features of septic shock, that is hypotension, decreased mean arterial pressure, increased level of serum lactate, etc. will be there. So like that, based on the complication, those symptoms also will be there. Now the recent reports say that so many CNS and psychiatric symptoms are seen in patients with COVID. That is, they will be having delirium, agitation, anxiety, depression, sleep problems will be there, features of encephalopathy, features of encephalitis, all these features of CVA in case of thrombosis. So these are the same CNS and psychiatric symptoms will be there. Then features of DIC will be there. Features of this pulmonary embolism will be there. Features of multi-organ dysfunction will be there. Features of SIRS, systemic inflammatory response will be there. Features of MODS will be there. Features of acute lung injury will be there. Features of atelectasis will be there. So all these symptoms will not be seen in one patient. The symptoms vary depend upon the clinical scenario in individual patient. Okay, so that is about the clinical features of COVID-19. I hope it is clear. Then I am going to explain about the complications of COVID-19. So when we look into the complications of COVID-19, there are different types of complications. I would like to classify this based on the lung related complications, prolonged immobility related complications, ICU and mechanical ventilator related complications, then coagulation cascade related complications, multi-organ dysfunction related complications. So in the lungs, what will happen? There is acute lung injury, atelectasis is there, and then pulmonary embolism may occur, ARDS occurs. These are the different things which is happening in the lungs. Then in case of ventilation and ICU related complication means there will be chance of this VAP, ventilator associated pneumonia, then catheter related infections, pressure ulcers, stress ulcers, then ICU psychosis, all those ICU related infection complications. So I told about lung complication, then I told about ICU related complication or immobility related complication. Then next is multi-organ dysfunction. That complication include AKI, acute liver injury, acute cardiac injury, which will include ACS, cardiomyopathy and all. Then CVA can occur. Then encephalopathy, encephalitis, delirium, I told agitation, all those CNS complications. Then DIC, I told, disseminated intravascular coagulation, that is another major complication. So these are the different complications of a patient with the COVID. Then in the severe forms of COVID, there will be sepsis, will be generalized sepsis will be there. Then septic shock will be there, SIRS will be there. So these are the different complications of COVID-19. I hope it is clear. In this video, I have explained about the structure of virus, mode of transmission, pathophysiology and clinical manifestations of COVID-19. And in the next video, I will be explaining about the diagnostic investigation, and the third video I will be explaining about the management of COVID, and the fourth video I will be explaining about the nursing management of COVID-19. Hope everything is clear. Thank you.